discuss with other patients how much you're getting or what you're doing, And I think that's a great rule, because I may respond to 200 milligrams, Jessica over here may respond to 100 milligrams. That doesn't mean that Jessica gets upset and says, how come he's getting 200, I'm getting only 100, I need 200. No, that's what works for her. Everybody's different. A Tylenol may take my headache away, and Keith might need 4 Tylenols to take his headache away. So it's very variable. But it also depends on the amount of pain, the CRPs you've had, how long you've had it, how widespread it is, the degree of your RSE would depend on whether you need an outpatient or an inpatient. The important thing is to minimize trauma while delivering the infusion. So, RSD patients should avoid trauma no matter what. No surgical trauma, no physical trauma, even a needle stick, even an IV stick is a bad idea. First, for some reason, RSD patients have poor veins and very thin veins. So getting an IV is tough. So it's really important that you have to minimize the trauma while getting infusion. A lot of centers that will do infusion on a regular basis will insist on having a chest ward, and it's amazing. If you're getting infusion on a regular basis, it's much better to have a chest ward. Now, again, ketamine infusions are only. I don't want you to think that ketamine infusions are the end all and be all of our treatment for RSD. It comes along with many other treatments, and we'll talk about all of those. This is the patient I have who, this is from I don't know when it was, but this was his right leg. He had severe RSD, right leg. Actually, he had RSD everywhere. This is after ketamine infusions, and then we started him on LDN. We will talk about that later on. Low dose naltrexone. Low dose naltrexone is, again, we talked about how locks and keys work in our body, and naltrexone is an old drug. It works as a dummy key. It works into the opioid receptors. It works into the keyhole where narcotics go and fit in. So basically what naltrexone does is it goes into this receptor and blocks it from this opioid working there. But we've also found out that it suppresses glial cell activation. You remember how those little blobs were getting red and inflamed? It stops that. We're not sure how it does that. There are a bunch of theories behind it. I didn't want to make it too sciencey over here, but I just wanted to explain to you, that's how it works. It doesn't work by blocking opioid receptors. That's not how it helps RSD. It helps by reducing glial cell activation. The dose can vary anywhere from 1 milligram to 4.5 milligrams. I do have some patients that go up to 6 to 8 milligrams, but that's the normal dose for low dose naltrexone or LDN. The normal dose for naltrexone, not for CRPS, is 150 milligrams. So this is a really low dose. You don't get it at a pharmacy, it has to be compounded. Initially it may cause insomnia, so what we do is, it's temporary. What we do is we have patients